X before we get started. Okay, sorry, I had to do that. So those of you who know me know that my passion has always been clinical photography. But the thing with clinical photography is that we use it to get case treatment approved, to show patients what their options are. So I'm going to talk a little bit today about how we can use clinical photography, which is historically one of the things that really doesn't sell cases, to help us sell cases and have powerful conversations with patients. So I run the Orthopreneurs Group. Some of you might have seen it. It was something started a little over 2 years ago. We have about 4,000 members right now. It's a wonderful group. If you want to come in, you don't have to pay anything. You can just go on Facebook, join the group. It's completely free. Be a part of it. It's where we share topics and things like HR, management, leadership, and do what we can to try to help each other grow our practices. So if you're not there, it's open only to doctors. Sorry if you're not a doctor. Hold on one second. There we go. When I spoke in Paris for Henry Schein last year, we had 89 countries that were represented in the Orthopreneurs Group. After I left there, I saw we got number 90, which was, sorry, there we go, Isle of Man. If you're anybody out there is a motorcycle fan, you know the Isle of Man. There are orthodontists in Isle of Man. Didn't know. So, the world is changing. Show of hands, anybody out there a Fortnite fan? Anybody ever play Fortnite? Anybody know anybody who plays Fortnite? Yeah, you'd have to live under a rock if you didn't know somebody. Well, the world is changing rather quickly because 3 years ago, if I said to you we have a game called Fortnite, you would have looked at me and said I was crazy. You wouldn't have known what I was talking about. The craziest part about it is, mark my words, 1 year from now, Fortnite will be down, and Apex Legends is going to be the next one. So keep your eyes out for that. The world is changing so quickly that what worked for us 6 months or a year ago no longer works. Google, Yelp, Facebook, that's where we get our patients from nowadays. I remember the days when I watched my grandfather, who was a dentist, and my dad, who was a dentist. They could barely advertise in the yellow pages. Nowadays, this is where our patients come from. So if you're doing what you've always been doing, especially in regard to digital case presentation, I want you to start rethinking that just a little bit. This is my world now. CBCT, clinical photography, scans, 3D prints. This is what I do on a regular basis. This is part of my regular exam, using CBCT as a way of communicating with patients, helping them better understand their processes. And it doesn't matter whether you're using a pan, Ceph, CBCT, scanner, photos, doesn't matter to me. I'm going to talk to you in the next 20 minutes or so about simple, easy ways to change what you're doing in your office in terms of communication so that you can watch your case acceptance go through the ceiling. And best of all is it doesn't take any more work. You don't have to radically change what you're doing. We're just going to tweak a few things just a little bit. So, let's talk a little bit about digital co-diagnosis. If you've never heard about it, maybe it's because I coined the phrase about 15 years ago. And what it is a process in which patients help diagnose a case themselves before any treatment is presented. Because historically, we show a bunch of photos, or we show a CBCT, or we show something on screen, and then we proceed to tell the patient all the problems they have. You see this, you see this, you see this, and they don't engage. So about 15 years ago, I came up with a concept called digital co-diagnosis, and I'll talk a little bit about it in just a minute. But it is a form of motivational interviewing. It's a newer thing in healthcare, and I'm going to teach you how to use this really, really powerful tool that won't cost you a penny, isn't going to take a lot more work, and it's going to allow you to see case acceptance skyrocket literally from the moment you use it the first time. Now, every picture tells a story, right? Yet you look at this picture, you know exactly what happened the day before to this poor gentleman. But pictures tell stories. If you're old enough, which nobody here is, you can remember what you felt when this picture was first put out. Maybe this one brings some emotion, and of course, we all know where we were that day. Pictures tell stories. And nothing's been shown to tell the story better in dentistry than photos. And best of all, as orthodontists, this is what we do on a regular basis. I first wrote about the concept of digital co-diagnosis in dental economics back in 2007, about 12 years ago. And I showed a little bit of stuff. I want you to look at all the things I put on this picture, which I don't even do anymore. I made it too complicated back then, and now I learned how to change it a little bit. So how is this different than traditional digital case presentation? Everybody says this is nothing different. Well, let me show you a couple of little things in just a moment that'll help you understand it better. First of all, it's completely patient-driven. Again, we do less work, not more. We don't sit around telling the patient what their problems are. They figure it out for themselves. The cornerstone is exceptional clinical photography, and that's what helps drives case acceptance through the ceiling. Fight the urge to treatment plan your patients when you're with them, and I'll explain to you what that means in just a minute. And of course, walk them down the path to discovery. Now, digital co-diagnosis, anybody here ever see My Cousin Vinny? So you remember when she's on the stand or he's on the stand and they're saying, what are these green things on these trees? And he says, leaves, and he walks them down the path. That's what we're going to do with our patients in a very simple and easy to understand way. And I'll show you how we do that. When I was a restorative dentist, which most don't know that I was a restorative dentist for 2 decades before I became an orthodontist. I went back to ortho at age 44, and I was doing tons of restorative cases, big, ginormous cases, $50,000, $60,000, $70,000 cases. Very difficult to get patients to understand what their problem is. Orthodontics is easy. Why? People come into our office knowing they have a problem, and they're actually looking for a solution most of the time. Unlike a person who comes in for a cleaning and doesn't realize they have 20 crowns they need to do. So for what we do, it's way, way easier. And one of my mentors, Dr. Morty Amsterdam, used to say, for every patient, there are multiple treatment modalities, but only one diagnosis. So we're going to fight the urge to treatment plan, which is what we typically do in the new patient consult, and we're going to just diagnose and let them help us figure it all out. So I'm going to ask you a question here. What is the most important image for patient engagement and motivation when we take a series of images? And I'm going to show you some images, and you tell me which one you think is the most important. I'm going to go through them a little bit, so you can definitely an important image when we present care to patients. Definitely important image. Pretty important to see this angle. Same on the lower, and I'll show you one more. Now, we're going to go backward just a little bit. Who thinks, from a show of hands, that this is the most important image for patient engagement? What about this one? This one? It's a pretty important image to look at the anteriors and see what those teeth look like. What about this one? Look at that lower anterior. I will tell you, without a doubt, both in restorative and in ortho, this is the most important image in ortho. There's no more image, no other image other than this that I can present to a patient that will get them to start treatment instantly. And I'm not talking about being immoral or untruthful or lying. I want them to diagnose the case. And this image, which I've been showing for years, I promise you, if you pay attention to this, you can implement this the second you get back to the office without any more money, time, or effort, and you will watch your case acceptance skyrocket. But the image needs to be taken well, and they need to be able to see it. And I'll explain to you how this works. You're going to take this image, and you're going to put it on your screen in your consult room, which I hope you're doing. But next to your screen, I want you to make a poster that looks like this. I want you to take a nice case that you finished, take it from the front, and take it from the lateral. And I want you to put it on a backer board that FedEx office or anybody else can make about this wide by about this high. And on top of it, I want it to say an ideal bite. That's it. This sits right next to your consult room screen computer. Just sits there. It'll cost you $15 to $30 to make. It will change your practice. Now, why is this important? Because I'm going to show this image on every single patient when I present care to them. They're going to see this. And what I'm going to say to them is the following. Do your teeth, or do your child's teeth, do they look like this, like a set of gears, and I go like this? Do they look like a set of gears that come together nicely? Or do they look like rocks banging into rocks? And they will say, don't answer it for them, let them answer for you. And they will always say, yeah, they don't look like that. I'll say, exactly. Now you can have a conversation. but you're not going to treatment plan. You're not going to tell them, well, we're going to make it look like this by doing this, 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 and this. Fight that urge. Because you're telling them what you're going to do for them. I want them to picture it in their head. I want them to understand. So what you're going to say to them is, do you see these teeth are here like this? Do you see the middle of this molar and where it hits relative to this molar versus this one? Would you say that your teeth, the upper, is ahead or in back of where it should be? And they're obviously going to say, it's a little bit further back than it should be. I say, exactly, you got it. So what do we need to do to your teeth in order to make them come together better? They understand it. It's called motivational interviewing. And the moment they hear the words come out of their own mouth, they own it here. So you're not selling them a solution. They're already looking for one. They already know what the problem is. So make this poster, if you will, doesn't need to be bigger than this, but put it right next to your screen in your consult room so when you show this image, they can see the difference. Now this is a good attempt, right? This is, if you're picking up a camera at all, you know, that's amazing. But when you try to do this with that quality of an image, it's a little more difficult. There's more distraction. I don't want distraction. I want this. Right, again, all they're looking at is teeth. They have the screen there, and they've got this. And again, if you have this, God bless you for taking pictures, but let's see if we can get them a little bit better. And it's important to keep in mind that this is an aesthetic image. It doesn't do anything for you. It makes us feel better. This is a digital co-diagnosis image. Right? This is something from which I can, and just so you know, I'm speaking at AAO tomorrow afternoon for teams and for doctors on really how to get these images. We don't have time for that today. But this is an image from probably 15 years ago. And this is all about the fact that it doesn't matter what camera you use. It's about mirrors and it's about retractors. And as long as you know how to manage your mirrors and retractors, you'll get images that look like this every single time. I want to touch on something real quickly because this is my soapbox I'm on today, so I'm going to have a soapbox moment. When I was a resident, I took a picture of one of my co-residents and I put a line through their cuspids and through the mesial buccal cusp and the buccal groove. Now, raise your hand if you think this is a locked-in class 1 occlusion. I won't put you on the spot. It's obvious it's not. Because this is what it really looks like. Now again, this is not a locked-in class 1. This is a class 2 end-on occlusion. But if you don't get a really good image, I don't want to say you're lying to yourself, but you just don't know. And do you remember what I just showed you about how to get your case acceptance through the ceiling? It's dependent upon your ability to show them rocks against rocks, or are you coming together like a set of gears? This looks like a set of gears. Sorry. My machine is being a little bit glitchy with me. How can I possibly tell this end-on class 2 that there's a problem when it looks like this? You can't. You've just taken one of the greatest tools you have for selling cases to your patients by having the wrong angle. So I will always tell you, I'd rather you lose the second molars in the picture and get me a straight-on class 1 or straight on, sorry, I would rather you get that. I apologize. We'll get there. I'd rather, if you have trouble getting a straight-on shot, I would much rather you lose the second molars and show all of this than to try to get the second molar and end up getting this kind of relationship. Because I'm telling you, if you can shoot straight on and show that analogy I talked about, patients will get treatment not because they want a better smile, but because they understand the value of having an occlusion that comes together properly. Now, the second reason I want you to get pictures like that is I just wanted to take 2 seconds here in the course of showing this to show some motion cases, just 2. That's all I want to show you here. Right? Oh, 1 case, sorry. Take a look over here. This is 3.5 months with a motion. 3.5 months from full class 2 to beyond class 1. And if you say that this is a postural effect only, I want you to look at the crowding around the 1, 2, and the 3, and look at the spacing around the 1, 2, and 3. I want you to look at the proclination of the upper front teeth, and I want you to look at the proclination of the upper front teeth on the lower picture. This is not a postural effect. But my point is, how do I objectively evaluate my cases unless my images look like this? You have to be able to look at your images properly so you can have intellectual honesty with yourself, because my outcomes matter to me. And if I can do this in 3.5 months and show this to a mom, that then we're going to do clear aligner therapy on this child, because I'm already halfway there. So again, photography matters. Do your best to get those shots. Here's a class 3. Again, I want you to look at the angle of the pictures. This is the key. Straight on. It allows us to objectively look at the proclination of the lower anterior teeth, which had nothing on it, and look at the way it changed. I can't do that without good photography. I can't have that conversation with you without that. So I really want you to spend time on your images. It's super important. So before we finish, I just want to walk you through this whole digital co-diagnosis thing. Because if you get it, case acceptance will go through the ceiling, and more importantly, patients will understand what it is you're doing, which creates a lot less friction in the office when you get into the meat and potatoes of some serious treatment planning. So, we're going to talk about this. I got rid of the facial pictures, and I'm going to walk you through this as if this was a patient in my office. We've already looked at the facial pictures. I have a smile picture here. I'm going to go past it a little bit. My restorative days have forced me to take a repose picture. The late, great Vince Kokich always talked about incise the ledge at repose and what's appropriate for a 35-year-old, about 3.5 millimeters. So I always like to look at this and see what we've got. But I want to just show you something as we move through this a little bit. Historically, what most of us do is we show a picture like this, and we say to the patient, look at your teeth and how worn they are. Look at the cracks in the teeth. Maybe, and this is another picture I love to take, maybe we talk to them about, look at the ridges on your teeth. Look at the way they look chipped. And we start talking to them about all the things we see, and we spoon feed it to them in a way that they don't really understand it. So we need to kind of walk them through it a little bit. So the way I would approach this patient is I would say to them, hey, when you look at your front teeth, do they look, and remember, what's next to my screen? My ideal bite, right over here. It's my reference. So I say to them, the teeth to the left of the screen or the right of the screen, do they look longer than they are wide, or do they look wider than they are long? And obviously they'll say they look longer than they are wide, and I'll say, right, because teeth should be about 60 to 80% width to height ratio. What do you think about your teeth? Does this tooth look wider than it is tall? And they'll say, yeah, it does. I say, exactly. So again, don't give up. What do you think caused this to happen? Were you born like that, you think? Or do you think something might have happened to it? And notice I'm giving cues. And they'll say, I may have worn it down. I say, exactly. Now, we can have conversations about what we're going to do. We can have conversations about how we're going to treat it. But the point is, they said to me the tooth was wider than it is tall. They told me they thought they wore it, right? They told me they chipped it. I did not convince them of that. And as we get into other things that are more ortho and less restorative, kind of like this, or like this, and they have the picture to the right of them, it's very easy for us to make the mistake like we typically do and say, hey, by the way, you notice how this tooth is tipped forward and there's a space is smaller now, and you have this thing called a crossbite, and we start getting into this? That's the easy way to go. The right way, and the simple way, if you will, is to say to them, when you lost this tooth, I think it was a first molar, right? So it's about the size of this thing here. What happened, do you think? They're all going to tell you it must have drifted forward. And then you can say to them, would you like me to talk to you about options to put it back where it started from? Or would you like me to talk to you about options to close the space up completely? I mean, now they're engaged and they want to hear it. When we talk about a crossbite, we don't say to them, look at the crossbite. We've got our picture right over here to the side that shows the lateral arch, and we say to them, what looks different between that picture and this? And they'll see it, and they'll say to you, the teeth look different. You say, exactly. And then you can have a conversation about where to go from there. And you're not selling anybody on anything. You're not trying to talk anybody into anything. What you're basically doing is just letting them get an awareness to where they become engaged, and when they're engaged, they get much more involved and want to get started with treatment. So the last thing I want to talk about real quickly is when we're done talking to our patients, don't just assume that because they're engaged, they're ready to get started. We need to make sure that whoever's going to follow up has a very good way of moving there. And I'm a big fan of a closer. And that means that my team has been trained in picking up the slack of where my digital co-diagnosis ends and where they're supposed to begin. So don't assume that just because you do this, all of a sudden everything works out. You've set the stage. You've got the lead. You need somebody who can then take it from there and offer proper financing and not screw it up, if you will. But it's very important to get there. This is important for me. Oops, sorry folks. Whether you think you can or you think you can't, you're usually right. And if you think you can do this, if you think you can do great images, if you think you can get digital co-diagnosis in your office, you will see remarkable changes in your case acceptance. You will see remarkable changes in your patient's engagement and referral patterns, because they're going to be the ones at the brunch, they're going to be the ones at the bar who are actually explaining to their friends what's going on in treatment. And it makes a big difference. And so tomorrow, I'll be speaking here, not here, but AAO, from about 3:20 to 4:20, and it's for teams as well, about how we really get into the nuts and bolts of photography and how we get the images like I showed you every single time, and a couple of other really fun things about how we can use that to grow our practices at the same time. So at the end of the day, it's really all about this, right? This is why we do what we do. It's great to make a living. It's great to be here on stage. But this is what I think about at the end of the day, because I have a lot of fun in my practice. I just want to show you one more thing real quickly. Anybody here a member of the Orthopreneurs Facebook group? So if you are, we have about 4,000 orthodontists there. It's free to join. Please go on to Facebook, join Orthopreneurs. It's simple enough. It's a place where we share ideas, concepts. It's doctors only, so we can speak freely about what we want to speak about. And the nice part is we have an annual meeting in September in Dallas, some amazing speakers. Henry Schein is lead sponsor, and you'll get to see some amazing things while you're there. The team track is completely sold out, no more room. Doctor track, about 85%. I would love to have you there. You'll see what it's like to go back to Gorp as a grown-up. That's what it's like. So that said, hopefully you listen to my podcast from time to time. Every now and then you get a chance. Luis was on there before, Lou Shimura, Scott Fry. I've got some really good people on the podcast. You can find it on iTunes. Definitely come by. It's an hour of basic pandemonium. I don't have a script. We just sort of chat, and I ask them the questions that everybody else really wants to hear as well. So hopefully you can come listen to the Orthopreneurs podcast. Definitely join the Facebook group, and I promise you'll get something out of it, and it doesn't cost you anything. Oops, last but not least, before we say thank you, if you ever need to get a hold of me, this is where you can get me. That's my personal email, doc@kriegersmiles.com. That's me on Facebook. That's me on Instagram. This is me on stage. Thank you so much for your time. I really appreciate it.
All right. Thank you, Dr.